Today we're discussing the topic antiproliferative and antimetabolic drugs. They are a type of immunosuppressive drug. There are different types of immunosuppressive drugs. There are corticosteroids, calcineurin inhibitors, antiproliferative and antimetabolic drugs, and then the monoclonal antibodies. Antiproliferative and antimetabolic. Antiproliferative, antimetabolic. It is against cell division, against the multiplication of cells, and it is against the metabolism of cells, against the metabolism of cells. So that's the gist of it. How is it immunosuppressant? Well, because it suppresses the cell division and the metabolism of leukocytes, of T and B lymphocytes, of neutrophils, of different types of immune cells. So if those cells are suppressed, then obviously immunity is also going to be suppressed. The first drug we're going to be talking about is sirolimus. Sirolimus, its important other name is rapamycin. They are both generic names. It is produced by a bacteria by the name of Streptomyces hygroscopicus. That's not that important. What is important is its mechanism of action. It works by inhibiting T lymphocyte activation and inhibiting the downstream proliferation of interleukin 2, interleukin 2 to prevent the immune cascade from fully getting activated. And it does so by forming a complex with FKBP12. Its receptor is named FKBP12. Now, if you've studied the other immunosuppressant drugs, calcineurin inhibitors, then you will know that another drug also acts on FKBP12. That is tacrolimus. Yes, tacrolimus and sirolimus, they act on the same receptor, FKBP12 receptor. But the exact mechanism of action is different, even though they are the same receptor. It actually, sirolimus, when it attaches on FKBP12, it causes a direct effect on mTOR, MTOR. MTOR mTOR is actually an acronym for mammalian target of rapamycin. Rapamycin, you will recall, is just another name for sirolimus. Just another name for sirolimus. So this gene mTOR is literally just the called the mammalian target of sirolimus. Very creative name, I know. So sirolimus acts on FKBP, which in turn acts on the mTOR gene. It is actually a gene because it is a lipid soluble drug. It crosses the plasma membrane and enters inside and acts directly on the nucleus. On the nucleus. So on the gene mTOR. Now, mTOR will be talking about that. mTOR is a very important gene because it is responsible for regulating cell growth and proliferation. One of its functions is to check whether the cell is ready to proceed from G1 phase to S phase. Now, when a cell moves from G1 to S, there's an important check over here. So there are checks and balances. The check over here is whether the cell is ready to proliferate, whether the cell is ready to duplicate its DNA or not. mTOR decides that. When sirolimus, when it binds to FKBP12, it inactivates mTOR. Once mTOR is inactivated, the cell is not allowed to move into S phase from G1 phase. It will forever be stuck in G1 phase. Hence, there will be no DNA replication. If no DNA replication, then there is no cell division and its proliferation is halted. So that's why it is an anti-proliferative drug. This all of this thing happens inside the nucleus of a T lymphocyte. So T lymphocytes do not proliferate, interleukin 2 does not proliferate, the immune cascade is not activated. That's basically all there is to it, to the mechanism of action of sirolimus. Okay, now you know the mechanism of action of sirolimus. Let's talk about its ADME, its pharmacokinetics, its absorption, distribution, metabolism, elimination. It is administered orally. Peak blood concentration in 1 hour. You don't really need to memorize the numbers, just get the gist of it. 2 hours in renal patients, 15% bioavailability, so not too much. Now, the important thing here is the therapeutic range for sirolimus is 5 to 15 nanograms per milliliter of blood. Now, the exact number is not important, but I kept it over here so that you can appreciate how little the therapeutic range for sirolimus is. 5 to 15 nanogram per milliliter of blood. 1 nanogram is a billionth of a gram. Just you need to stay within 5 to 15 of that for it to be therapeutic. Like that's a really narrow range to work with. So that is why we need to do TDM, therapeutic drug monitoring, for sirolimus, because one of the indications of TDM is very low therapeutic range. So that's that. Let's continue with the ADME of sirolimus. Okay, I did a mistake. This is not when ADME, sirolimus ADME continued, not TDM. See, TDM is very important for sirolimus that I confused it and wrote TDM instead of ADME. So that's another memory aid, I guess, that do TDM for sirolimus. 40% of sirolimus is protein bound, especially to the plasma protein albumin. It is mostly bound to albumin. What does this say about sirolimus, its nature? It is a weak acid. Drugs are either weak bases or weak acid, and weak acidic drugs, if they bind to plasma protein, then they are going to bind to albumin mostly. Mostly. It is sirolimus is metabolized by CYP3A4. Can you guess where it is? Yes, it's in the liver. It's an enzyme system in the liver. Some of its metabolites are also active. Some of sirolimus metabolites are also active, but 90% of the immunosuppression comes from sirolimus itself. The rest of it comes from its active metabolites. Half-life of 62 hours and loading dose is 3 times the maintenance dose. Again, you don't need to know the exact number. I just wanted to give you an idea of it. Let's look at the therapeutic uses of sirolimus. It is used as prophylaxis, something of a precaution for organ transplant rejection. Organ transplant rejection is an important therapeutic use, not just for sirolimus, but for most of the immunosuppressants. Okay, so it is usually used in conjunction with calcineurin inhibitors or glucocorticoids. Glucocorticoids and calcineurin inhibitors, they are more important immunosuppressants than antiproliferatives, but we use it in conjunction with these. Now, they are also used with glucocorticoids and mycophenolate to prevent renal damage. Mycophenolate, we'll be talking about it later. Now, to prevent renal damage, we use this combination, and it is also incorporated into stents to inhibit local cell proliferation. Like if you put a cardiac stent into a person's heart, there's a very artistic drawing of a human heart. Now, there's a vein over here, and if it is occluded, we put a stent in it. A stent, it's kind of a mechanical piece, a very small one that's put into the coronary veins to remove the occlusion, to remove the atherosclerosis from it. And we also use this drug over there to prevent the local cell proliferation by keeping it stuck in the G1 phase. Let's discuss the toxicity of sirolimus. It is dose dependent. Dose dependent, this toxicity is dose dependent. Decrease in serum cholesterol and triglycerides resulting from sirolimus. Patients with sirolimus plus cyclosporin have delayed immune function, many prolonged delayed grafting, and prolonged delayed graft function. Okay, delayed graft function is one of the toxicity from sirolimus in deceased donor recipients. So if a person is receiving an organ donation from a deceased person, then then the received organ will come into function slowly. Can you guess why? Well, because the graft which is given, this graft which is given, the organ that is given from the other person, it needs time to grow, right? This gets slowed down because the cells get stuck in the G1 phase simply. And again, cells are stuck in the G1 phase, so wound healing would be delayed if you use sirolimus. Those are its toxicity, its adverse drug effects. Let's look at its drug interactions. If any drug has CYP3A4 metabolism, then it is going to compete in its metabolism with sirolimus. So there's an interaction for you, a pharmacokinetic interaction. Drugs transported by P glycoprotein also have this interaction with sirolimus. Oh, and I should have written it in the ADME that sirolimus is transported by P glycoprotein. It is bound to albumin, but it is transported by glycoproteins. And its dose needs to be adjusted when administered with rifampin. Okay, so those are its drug interactions. Now let's talk about another drug. Sirolimus is done. Let's get to everolimus. Everolimus, it's easy once you've studied sirolimus because it is also an mTOR inhibitor, just like sirolimus. It has very similar pharmacodynamics to sirolimus, same pharmacodynamics, but distinct pharmacokinetics. Pharmacokinetics are distinct because it has a smaller half-life, but pharmacodynamics are the same. It is also an mTOR inhibitor, same mechanism of action. Similar toxicity and interactions to sirolimus. Okay, so that's this about everolimus. It's basically an analog to sirolimus, very similar. Now we have azathioprine, a different drug. We've talked about sirolimus, everolimus. Now we're talking about azathioprine. Azathioprine, it is a purine antimetabolite. We're talking about antiproliferative and antimetabolic drugs. This is antimetabolite. It is an imidazole derivative of 6-mercaptopurine. Now, I'll be showing the structure and we'll be studying it better. But here is the gist of its mechanism of action. It inhibits de novo purine synthesis. Okay. If de novo purine synthesis is inhibited, then obviously cell proliferation and lymphocyte functions will be inhibited because without purines you can't replicate DNA. Purine is an important component to DNA. Is the structure of azathioprine. Now, just the moment you see this structure, you should notice this guy over here. Now, if you've paid attention in biochemistry, you will know that this is a purine ring. This is the structure of purine. So, a purine is attached to azathioprine. That is why it is an imidazolyl derivative of 6-mercaptopurine. Mercapto is simply this over here, this sulfur over here. It is a derivative of 6-mercaptopurine. So, this is a purine. This is its sixth carbon, sixth position on the sixth position of the purine ring, and SH would be attached over there. This is the mercapto group. Mercapto group, 6-mercaptopurine would be this one, SH attached to the sixth one, but it is an imidazolyl derivative. So this whole thing is the imidazolyl. It is attached to the mercapto derivative of to mercaptopurine, 6-mercaptopurine. Now, the way it's going to work, the way azathioprine is going to work, is that it goes inside the body. Azathioprine goes inside the body. This whole thing goes inside the body, and then it breaks down. It breaks down into 6-mercaptopurine. 6-mercaptopurine is the structure that I had shown already. This thing is 6-mercaptopurine. This over here is 6-mercaptopurine. 6-mercaptopurine breaks down into 6-mercaptopurine, and actually 6-mercaptopurine is going to do all the things, all the actions of the drug. Okay, so 6-mercaptopurine, it has three fates, either by xanthine oxidase. XO is xanthine oxidase. By xanthine oxidase, it is going to be converted into thiuric acid, which is of no use to us, but it is non-toxic and inactive. And by the action of the TPMT enzyme, thiopurine methyltransferase, thiopurine methyltransferase, it gets converted into methyl mercaptopurine. But the main thing that we want is just naturally it gets converted into 6-thioxanthin 5' monophosphate. 5' monophosphate, which gives rise to 6 MMP ribonucleotides and 6 thioguanine. Both of these, they are the toxic analogs of purine. They look like purines, they mimic purines, but they are not purines. So they are going to, this is a fake guanine basically. Fake guanine is going to interfere, is going to replace real guanine. And so when DNA replication is going on or when transcription is going on, this will be recognized, the fake guanine will be recognized and it will terminate replication or it will terminate transcription, whatever. And because of that, the proliferation and functions of the lymphocyte will be inhibited, which will lead to our ultimate goal of suppressing the immune response. So that was the pharmacodynamics of azathioprine. Let's discuss its ADME. It is administered orally, again, just like sirolimus and everolimus. Maximum blood levels in 1 to 2 hours. The half-life of azathioprine is very less, in just 10 minutes. So it gets broken down into 6-mercaptopurine really quick. And 6-mercaptopurine has a 1 hour half-life. Extensive metabolism, high tissue levels, high volume of distribution. TDM has little predictive value, so don't do TDM for azathioprine, but you should do TDM for everolimus. It is moderately bound to plasma proteins and removed from blood by oxidation or methylation and or erythrocytes. Therapeutic uses, again adjunct, meaning it is used in addition to glucocorticoids and calcineurin inhibitors. For preventing organ rejection, it is used in rheumatoid arthritis and autoimmune disease. So yeah, that makes perfect sense to use an immunosuppressor for an autoimmune disease. And in autoimmunity, the body's immunity is attacking the body itself, so you suppress the immunity. Complete blood count and LFT should be monitored. Should be monitored when you're using azathioprine. Because again, it is eliminated by RBCs also. So you need to keep doing the complete blood count, and you need to see how much the leukocyte and the thrombocyte level has been lowered because it is going to stop the proliferation of blood cells, right? So even thrombocytes and leukocytes and erythrocytes are going to be decreased in their proliferation since guanine is replaced by an evil cousin of guanine. So yeah, that's that. That was about azathioprine therapeutic uses. Let's look at its toxicity. So there is more marrow suppression than you would like sometimes. Leukopenia is common, decreased WBC count. That's the goal, right? To decrease the immune response, to decrease leukocytes. And there is thrombocytopenia, which is less common, but still does happen. And anemia is even less common than thrombocytopenia. But these are possible toxicities, as we've already discussed. It increases susceptibility to infection since your immune response is lowered, and also has an increased susceptibility to neoplasia. Now, you might think, why does it have an increased susceptibility to neoplasia? It's stopping cell proliferation. But it does have an increased susceptibility to neoplasia because, well, you're hurting the process of DNA replication and of transcription. So for the little cells that do proliferate, they are likely to have, they are more likely to have neoplasia than otherwise. So those are the toxicities for azathioprine, and here are its interactions. Xanthine oxidase is blocked by allopurinol. When we talked about its mechanism of action with the diagram over here, xanthine oxidase is one of the important enzymes in its metabolism. This xanthine oxidase is one of the pathways for metabolism of 6-mercaptopurine. And the thing is, xanthine oxidase is also the enzyme that's needed for the metabolism of allopurinol. Allopurinol is the drug you use to treat gout. So it competes with the gout drug allopurinol for metabolism. That's one of the interactions. Another interactions is using azathioprine with ACE inhibitors, angiotensin converting enzyme inhibitors. It causes increase in leukopenia, thrombocytopenia, and anemia than usual. That was all about azathioprine. The last major drug that we're going to be talking about is mycophenolate mofetil. Mycophenolate mofetil. It sounds like a long name. That's because it is an ester. It is an ester and it is a prodrug, meaning it's just a pro means before. So it is a form of the drug. It is not the active drug that's going to cause its mechanism of action. It is going to be metabolized into the active form. Okay. It is actually an ester of mycophenolic acid, and mycophenolic acid is the active drug. Mycophenolic acid is the active drug. Its ester is mycophenolate mofetil. When it reaches an acidic environment, the acidic environment of the stomach, this ester is going to get hydrolyzed. Ester is going to get hydrolyzed, and its hydrolysis will result in the active drug that is mycophenolic acid. Okay, so now let's talk about its mechanism of action. Mycophenolate mofetil, its active form mycophenolic acid, is a selective, non-competitive reversible inhibitor of an enzyme. That enzyme is inosine monophosphate dehydrogenase. Inosine monophosphate dehydrogenase, if you recall your biochemistry class, is important for de novo guanine nucleotide synthesis. De novo guanine nucleotide synthesis is important to get guanines. Guanines are important because you want to make more DNA to proliferate the cell that we want to. So the cell wants to proliferate by creating more guanine and adenine and all the all the nucleotides, okay, all the nitrogenous bases. You're stopping de novo guanine nucleotide synthesis by using mycophenolate mofetil by inhibiting IMPDH, inosine monophosphate dehydrogenase. Continued its mechanism of action. So this inhibits B and T lymphocytes because B and T lymphocytes actually they use de novo guanine synthesis more than the other cells, and we're exploiting this by selectively inhibiting B and T lymphocytes. Okay, they make more use of de novo guanine synthesis than the other cells. And by virtue of this property, mycophenolic acid, the active form of mycophenolate mofetil, selectively inhibits lymphocytes and suppresses the immune response. Let's talk about its pharmacokinetics. It is very rapidly metabolized to mycophenolic acid. You're just breaking down an ester, and the acidic environment is provided by the stomach. It is given orally or intravenously. It is metabolized to inactive glucuronide MPAG, mycophenolic acid glucuronide. This is phase 2 metabolism. If you remember your pharmacokinetics, phase 2 metabolism, and it is excreted in urine in the same form as mycophenolic acid glucuronide. Therapeutic uses prophylaxis for transplant rejection, just like most of the immunosuppressive drugs. It is typically combined with glucocorticoids and calcineurin inhibitors, just like all of the antiproliferative and antimetabolic drugs that we've discussed until now, and do not combine it with azathioprine. Azathioprine, the one which we already discussed, the purine synthesis inhibitor. Okay, so that's about that. Let's go to mycophenolate mofetil, its toxicity, GI and hepatologic toxicity, because that is where it is metabolized. Leukopenia, leukocyte number decreases. RBC aplasia. Aplasia simply means abnormal formation of RBC. Abnormal RBCs will be increased by mycophenolate mofetil. Diarrhea and vomiting, the generic ones. And it makes the patient more prone to cytomegalovirus infection. As the immune response is weakened, the patient is more prone to cytomegalovirus infection. It has interactions with tacrolimus because tacrolimus delays its elimination, which may enhance its toxicity. Co-administration with antacids leads to decreased absorption of mycophenolate mofetil. Why do you think this might be the case? Why? Because antacids lower the pH. Antacids lower the pH of the stomach, they increase the pH of the stomach. They make the stomach more alkaline. The stomach becomes more alkaline. If the stomach becomes more alkaline, the hydrolysis of this ester becomes difficult, and then yeah, you won't get the active form that easily. The next, so mycophenolate mofetil, that was the last major drug we were discussing. Methotrexate, it has a bit less of the explanation as the other drugs because it is mainly an anti-cancer agent, but we can also use it as antiproliferatives. There's a good overlap between anti-cancer drugs and antiproliferatives and anti-metabolic drugs because you're stopping proliferation in these drugs. That is very similar to our aim with cancer, anti-cancer drugs. Okay, so methotrexate, it is a folate antagonist. Folate antagonist, just like a certain antibiotic. That's right. Just like cotrimoxazole. I just wanted to insert that over here to increase retention of that. Yeah, but this is also a folate antagonist. That is in bacteria. This is a folate antagonist in humans. It depresses cytokine production and cellular immunity. Okay. If cytokine production is decreased, then the immune response is decreased. Inflammation is decreased. So it is anti-inflammatory. Depressing cytokines depresses inflammation. It is used in rheumatoid arthritis, useful for rheumatoid arthritis, methotrexate, and it is a well-tolerated drug. There are less number of adverse drug reactions to methotrexate. Next drug is chlorambucil, weak immunosuppressant. Chlorambucil is a weak immunosuppressant, sometimes used in autoimmune disease, and it is used in maintenance of transplanted organs, maintenance of the graft. So that was about chlorambucil. And to make this slide, I've used knowledge information from Goodman and Gilman's Manual of Pharmacology and Therapeutics, second edition, and from K.D. Tripaঠি's Essentials of Medical Pharmacology. So if you think anything is wrong over here, then take it up with them and not with me. So that was all for anti-proliferative and anti-metabolic drugs. Thank you very much.